She specializes in the treatment of complex chronic conditions, including anxiety, fibromyalgia, depression, insomnia, and chronic pain. Dani will lead us through a short overview of how cannabinoids work in the brain and body. Please welcome Dr. Dani Gordon.
Thank you. Fantastic. Thank you. And one small correction, I am from Canada and I practiced there for many years, but now for the last 3 years I've been based in the UK, London, so now my practice has taken me across the pond where cannabis medicines are quite a lot newer, and that's where my current practice is. So I'm going to walk you through some basics first. Do we have any medical doctors in the audience who are prescribing or would like to prescribe or are interested in medical cannabis potentially in their practices? Any hands? Okay, I see a few. So what I'm going to share with you is some basics if you have not started prescribing or you're thinking about it. And it's going to seem very black and white. And of course, as we've heard from our lovely presenters already, this is not a black and white area. There's a lot of nuance, but I'm going to try to make it as simple as I can so people feel that they can get started, clinicians can get started. And if you're not a clinician, that you feel like you can have a base understanding, because I think it's really important to have the base understanding so we can dig a little bit deeper. So I'll just glaze over these very briefly, but cannabis, as we all know, preaching to the converted here, it is not a new medication, it's not a new substance. We've been using it for thousands of years in many different cultures for many different purposes, including medicinal use, spiritual use, for chronic disease management. And the use of botanical medicines, I'm a conventionally trained medical doctor, but I am also an integrated medicine doctor. So I give people drugs when I need to. I give people cannabinoids, and I give people botanicals, and I teach them how to do things like meditate. So botanical medicines are also not new. And despite what many people think in Western medicine, most of your patients are probably using some type of botanical medicine, and they're just not telling you about it. So cannabis is a drug. It can be a drug. It can be a medicine. It can also be a botanical medicine. And most of our patients, at least half of them, are using some form of botanical. This is, they're lower cost for patients. It's often more available than a Western medicine in many parts of the world. So it's just good to frame it in this way. Cannabis is quite unique, however. I was using botanicals alongside drugs in my practice for years before I officially added cannabis. And that was due to a lot of the misinformation, stigma that we heard about from Professor Hart earlier. And, the reality is this: cannabis can be used in such a wide variety of conditions and situations. You can apply it to the skin, you can ingest it, you can inhale it, you can even use it rectally, vaginally, you can use it to affect so many different systems. And it's also, of course, a health supplement in the unregulated markets. And this is important because cannabis is actually a wonderful medication and substance for the treatment of many complex chronic conditions. So in my medical practice, it is very rare that I cure anything. This is chronic disease management. My patients have come to me with what they would say is a shopping list of diagnoses, medications. It's very, very long usually. They're often overlapping symptom clusters. It's called transdiagnostic clusters, which means they have a bunch of diagnoses and the symptoms all cross over each other. That leads to what we call problematic polypharmacy, which is a very fancy word for saying lots of medications lumped on top of them, one for each symptom, lots of side effects, add some more medications, and then it's just big glob at the end, and patients and their physicians no longer really know what is doing what. And this costs a lot of money, chronic disease management. So, I also completely advocate for the use of cannabis-based medicines in patients because it's a cost-saving measure for the healthcare system. These medications are certainly sometimes, more expensive than they should be, especially in the UK, but the costs will come down. And they're just really good at treating a lot of these chronic conditions that are completely expensive. They cost billions of dollars. They're poorly treated. And we have a plant sitting in front of us that can help us tackle these epidemics. Even obesity, people think cannabis is going to make them have the munchies and become obese. But in my practice, I have found that actually many patients, when I put them on medical cannabis, they actually lose weight. Now, I can't say for sure that that's because of the cannabinoids, although in animal models, we certainly know that CBD has some early preclinical evidence with helping with blood sugar control. So there probably is a cannabinoid-specific mechanism. But also, when you give patients cannabis-based medicines and you get rid of the polypharmacy or you reduce it, and they get better, they start exercising more because they have less pain. They can go outside again because they don't have such bad anxiety. And then they start doing the other things that make their weight control, their pre-diabetes control, their diabetes controls better. Okay, so that's from a cost perspective. We've heard about the endocannabinoid system. I like this mnemonic: eat, sleep, relax, protect, forget. And just as Dr. Goldstein has very well pointed out, the brain, the immune system, in the gut, this is where the cannabinoid, the endocannabinoid system is concentrated. And all of my complex chronic disease patients, they have a lot of symptoms in these systems that are often not put together by a lot of my Western medicine colleagues. And it's probably because there's an endocannabinoid component. I'm just going to go through these. So there's many more cannabinoids in this, but what I'm going to focus on first, just for the basics, is how we prescribe clinically right now. This is probably going to change in the future. It's already changed since, Bonnie and I started prescribing. But just a few little points of interest, really. The first one is this whole cannabis sativa versus indica debate. When we prescribe medical cannabis products, they're often still labeled as an indica or a sativa. And even though that's technically inaccurate, these are all different chemovars. There's really no kind of sativas or indicas purely anymore. There might be a few. Everyone's kind of married their cousins in the cannabis genetics world, so everyone's a hybrid. However, it's still useful as a baseline for clinicians, because if it's labeled as an indica and it's a reputable company, you would hope that they've tested it to say that this is more of a nighttime, a more kind of sedating product, versus a sativa labeled product is a more daytime product. That being said, thankfully, we're moving towards the chemovar classification, which is actually what is the minor cannabinoid, the terpenoid profile of that strain, which is much more scientific. And we're going to be able to get more and more data, real world data, as time moves on. However, all that being said, I still have some patients where you put them on what you think is going to be the best starting product for them based on the availability in the market, and they respond, in a way you wouldn't expect. So, you give them a indica labeled THC oil and for their sleep and their nighttime pain, and it makes them more wakeful. You switch products, and generally you can find a product that works for them. That's a really nice thing about this group of medicines, because it's a group of medicines. This is not a single medicine. And this is something I do a lot of teaching for doctors. And this is one of the concepts. It's really hard for us as Western medicine doctors to wrap our heads around. Because I was already trained in botanical medicine as well, this is a little bit easier for me to understand, but it's still difficult because doctors say, well, what's the active ingredient? I just need to dose it based on that one thing. What is the dose, the starting dose? I'll make it the same for everyone. Cannabis doesn't work that way. You really have to use the art of medicine with these products, and you have to partner with your patient. So this is just a very busy slide, but it's just showing an example of some of the non-psychomimetic, the non-intoxicating minor cannabinoids in the plant that have a lot of biological activity. We don't have big studies on a lot of these things yet. But clinically, we see some interesting things. And, as Dr. Goldstein pointed out, she was seeing trends in her clinical work far before the research came out. And I had the same experience with adults. I only prescribe for adults, although I'm a huge advocate for pediatric use. So it really mirrors, though, in the adult population, what Dr. Goldstein has already shared. So most of you probably already know a lot of these things, but CBD is the base of cannabinoid therapy for most medical cannabis patients. There are exceptions to this, but if you are a new clinician starting out, you're usually going to use a 20-to-1, a 30-to-1 CBD THC oil, full spectrum oil. I use full spectrum products. And it has, a lot of different effects. And when people, mostly doctors, regulators, I do some regulatory work with the government as well, they say, well, how does CBD possibly help with all these things? It must be a snake oil. Well, if you look at the endocannabinoid system, you look at all the organ distribution and you look at what it does, and there's lots of things we don't even know that it does yet because it's not binding to the CB1 or CB2 receptor strongly. It does this kind of regulating effect. CBD has like a modulating, a balancing effect on the endocannabinoid system as well. That's how it can do so many different things. So it does have a scientific reason behind all these various effects that it has. Now, coming from the botanical medicine world, we have these things called adaptogens. Western medicine kind of laughs at this and says that's just a bunch of rubbish. But, adaptogens in botanical medicine are plants that have been used for thousands of years in different traditions that have been shown to help with chronic stress-related conditions. And how it probably does that is it modulates the immune system and the HPA axis on some level, potentially working with the cortisol axis, the stress response axis, and some other activity, which we don't totally know how it works. But CBD it functions like an adaptogen too. So oftentimes I will use a high CBD oil, and I'll use it alongside some other adaptogen herbs too for stress-related chronic illness. And it seems to really help. THC, it's the most divisive ingredient, cannabinoid, because it is psychomimetic. I like the word psychomimetic, although it's a tongue twister, rather than psychoactive, because psychomimetic means it can cause intoxication or an altered state, versus CBD is psychoactive, meaning it is active in the brain, but it does not cause altered states, or intoxication, as you will. THC is very useful. So, when I have patients who come to me with functional digestive disorders, I have a lot of these people in my practice. They might be trying a hemp-based CBD product already, have heard it's good for them, not really working. They have a lot of spasm in their gut. THC is an antispasmodic. You add a bit of THC in, and they get a better result. THC can be used in small doses, as we've heard from Dr. Goldstein, in epileptic disorders, chronic pain. It's really essential. Again, a lot of patients that see me have already tried hemp CBD oil for chronic pain, and then they go away thinking cannabis doesn't work. But actually, it's because they need a little bit of THC. And the amount of THC that people need really depends on the person, their endocannabinoid system, and what other medications they're on. I find patients on opioids often need more THC, especially when we're doing this cross taper. We want to wean them down off the opioid patches. We want to wean them slowly up on the cannabis. And if you just do that with CBD alone, it just doesn't work. What else do I want to say about that? I think that's it. Appetite stimulant. So I do have patients a lot of my patients have metabolic syndrome. A lot of chronic disease patients suffer from metabolic syndrome, which is kind of a pre-diabetes subset, altered blood sugar metabolism, that sort of thing. And one of the reasons is probably due to inflammatory markers kind of circulating and floating around and causing some of these metabolic problems. Now, they're really concerned, and I'm concerned, of course, especially when I first started out, that they're going to get the munchies and gain weight from cannabis, from THC. THC can cause appetite stimulation, but what we find clinically is when you use the right ratio of cannabinoids, meaning you add a lot more CBD than THC, you change the strain, you change the chemovar, there's some minor cannabinoids that are appetite suppressing, you can generally find something that does not cause appetite stimulation. So I'm always asking my patients about this in case we need to switch products, but generally it is something we can avoid with the right recipe. All I'm going to say about terpenes in the interest of time is that they do appear to cross the blood-brain barrier, which is really interesting. So I treat a lot of neuropsychiatric symptom clusters. What does that mean? So patients with chronic fatigue syndrome and ME, long COVID more recently, patients with anxiety and depression and gut symptoms where their gut symptoms may be contributing to their mental health symptoms and vice versa. It's like this bidirectional gut-brain axis. And involved in this process may be this idea that sometimes in these patients, we might get a leaky blood-brain barrier happening, and these immune cells in the brain called the microglia get more activated and when they shouldn't be and cause problems. So anything that crosses the blood-brain barrier from the cannabis plant is really interesting. What is that doing? We don't exactly know yet for each individual terpene, but what we do know is when we use whole plant extracts with the entourage effect that you've already heard about, patients get a better response at a lower dose, which means less side effects, less costly, and happier patients. CBG has been most well known so far for its, preliminary promising research using alongside together with conventional chemotherapy agents in glioblastoma, which is a very aggressive form of brain cancer. But now we're learning more and more that it has other properties too, probably some anti-anxiety properties, but we don't have really big studies yet. I haven't used purified CBG in my practice because it hasn't been an available product. But of course, it's a minor constituent in a lot of the strains we use. And THCV, has an appetite suppressant quality. So back to that whole THC munchies issue. This is really interesting. So CBN is a breakdown product of THC, and very early on, I started to notice from my patients, it's amazing what happens when you listen to your patients. And in integrated medicine, we generally have longer appointments. It's a more collaborative approach. And I had patients who kept saying to me that they would reuse the old cannabis in their chamber from their vaporizer, and they would actually like it better than putting a new cannabis lot in. And they found that it was they were less likely to have THC associated side effects, but still get control with their pain, and they found it calming. So that was before any of the CBN research came out. So it's probably because it had more CBN, because when you but when you heat in a vaporizer without burning it, ideally, the plant material, you turn a lot of the THC into CBN. There are pharmacological cannabinoids that have been isolated. Some are synthetic, some are natural. I generally don't really use them in my practice, except in cases, again, this has mostly been back in Canada. Now in the UK, I'm using full plant because no one can get Epidiolex covered anyways, really. But in Canada, there's a few patients who could get Epidiolex covered. So same thing, they would use Epidiolex as a base for their CBD, and then we would add artisanal products in lower amounts as they could afford it. Generally, I just don't find they work as well as full spectrum products. So that's that. There's lots of different delivery mechanisms for cannabinoids. Medicinally, of course, we don't want to smoke it, because when you smoke things, you burn the hydrocarbons in the plant, you cause inflammation, you cause byproducts that are not good, free radical formation, all that kind of stuff. So you want to vaporize it, and then we can give it to them by mouth, and an oil, which you hold under the tongue, you take with a fat, as Dr. Goldstein's pointed out. Sublingual and topical, rectal, vaginal. I've treated small numbers of patients, but patients with chronic prostatitis, interstitial cystitis, who have been refractory to other treatments with these more localized forms of cannabis. And there's not commercial products. So it's very picky, unfortunately. You have to capsulize their oil, and they have to do this themselves. But in the future, we're going to have these products available. It's going to happen. I'm going to skip this. I'm talking about cannabis. Actually, we'll talk about that. It's kind of interesting. So some people might have seen this cannabis tea idea. So what happens when you put cannabis flower, cannabis, let's say, containing high THC, for example, in a tea? I do this sometimes with my cancer patients, because when we are putting someone through chemotherapy and we want to give them control with their nausea and vomiting and their anxiety with a cannabinoid, oftentimes they don't want to take an oil. It already kind of upsets their stomach, and they're feeling quite nauseous already. And a lot of my cancer patients don't want to inhale anything. They have an association with smoking, even though vaporizing is different. A lot of my patients are older who are in the cancer population. So sometimes you can get them to put it in a tea. And some research from Arno Hazekamp in the Netherlands has found that you get actually more THCA, because THCA is more water soluble than THC. Cannabinoids are very water hating in general. So I find when I do this with my cancer patients, maybe it's a small amount of THC relative to THCA, we don't know, but they seem to get some good effects. I haven't done a huge amount of patients, but the ones I have get good effects from their cannabinoid therapy in an acceptable format for them, without THC side effects. So it's just another way you can use it. There's just so many options. CBD isolate, I'm going to skip over this. I don't use it in my practice, but it's in a lot of over-the-counter supplements, cosmetics, etc. Okay, this is where we want to get to. So all of these conditions you see here are things that I have treated with cannabinoids clinically. No, I do not cure these conditions with cannabinoids. I want to be very clear. But these are patients who have come to me with really treatment-resistant symptoms. And just like Dr. Goldstein has said, I do not believe this should be a last resort medication, especially in the UK, where I do a lot of policy work, a lot of mentoring work, as well as my clinical work. We are quite limited by how we can prescribe these medications. I mean, it's quite ridiculous. You know, you have to have tried basically everything before you can prescribe. But there are ways around it. There's some wiggle room in there, luckily. For example, I count CBT and psychotherapy as a medication trial because that is something that has proven efficacy for depression and anxiety. So if they've done that and they've tried an SSRI, then we feel that there is a case to be made for trying a cannabinoid. But eventually, hopefully, patients will be able to decide, no, I don't want to try an SSRI. I would like to try a low THC, high CBD cannabinoid medicine first. And I really believe that with informed consent, that they should be able to do that. What else do I want to say about this? The results can take some time. So patients have to be patient. And you have to tell your patients this. A lot of physicians, when they first start prescribing medical cannabis, and a lot of the mentorship that I do is about starting low, going slow, but giving it time to work, because the endocannabinoid system, as Bonnie's pointed out, it takes time to adapt and to change, and we don't want to ramp things up too quickly, because then you can potentially get more side effects if you're using higher THC, and you're just ramping up the cost for this patient. But you have to let the patient know, because otherwise they can get impatient and they think, oh, it just didn't work for me. So I have had patients where we have gone slow because a lot of them have been on a restricted budget. It's taken them 6 months to get the effect that they were looking for. And these are symptoms more in the neuropsychiatric bin versus, pain and sleep. If you get the right dose of THC in the right strain, the right product, you get the result in, days normally. What else do I want to say about this? Reducing the pill burden. It's just such an important thing to do for our patients. The pill burden is so high for some of these chronic disease patients. And it's not uncommon for me to see patients who have been put on medications that have not been reassessed properly for years, because one doctor started this, then another doctor started this, then the third doctor didn't want to discontinue what the second doctor prescribed because they were afraid that, I don't know what they were afraid of, but they just didn't. So I end up with these patients who they really need like a whole medication review, as well as looking at their cannabinoids. This is a common cluster of symptoms that I see in my patients, and it may be related to an endocannabinoid deficiency syndrome. There's some preliminary evidence. I think the work that Bonnie's doing is amazing with the metabolomics, pharmacometabolomics work, because this is what we need to kind of tease all this apart. But interestingly, a lot of the patients that I first had, my first patients with cannabis, had some of these clusters. Because I do integrative medicine, I attract patients who have things that are poorly treated by Western medicine, and they're often dismissed. I've had many fibromyalgia patients, not so many in recent years, but when I first started 10 years ago, told that fibromyalgia didn't exist. It was all in their head, just, really unhelpful things, really unscientifically correct things. But when you put them on cannabis, all of these symptoms get better. It's really, really cool, because often they're on a triptan and an opioid for their migraines. And then they're using more and more triptans over time. Then they get triptan overuse headaches. And then they have fibromyalgia pain. And then they're on an opioid for that, and they're on a gabapentoid. Oh, and then they're on a sleeping medication, and they're feeling hungover from that. Oh, and then they're IBS. Let's put them on an SSRI. Let's see if that works. And, what else can we try? So it just becomes this whole storm, again, of medications that are not really that effective. And I am not anti-medication. I'm standing up here, having to take antibiotics myself today for a UTI. So thank God we have them. But it's better when we can minimize their use when they're causing more problems than they're solving in the context of chronic disease. And this is it's a fairly old study now, but it's still really a good one to point out that what patients are saying about their medical cannabis and fibromyalgia. So this is a study of the approved pharmaceuticals versus cannabinoids in patients with fibromyalgia, and how well they think that their medications were working for them. And as you can see, cannabis is coming out on top versus the first line options for fibromyalgia, which are, to be quite frank, quite poor. Okay, so these are some really simple slides. It's more complicated than this, but I just want you to have some really simple take-homes. One of the most common prescribing mistakes I see in psychiatry with cannabinoids, and I do a lot of prescribing in psychiatry with anxiety disorders, is using a balanced product, so 50-50 CBD and THC from the get-go with patients with anxiety disorder. Sometimes it works all right, but over time, sometimes the biphasic effect of THC, they get over the amount that, because THC builds up in the body over time, they get past the amount where THC is helping their anxiety, and then it starts to actually make their anxiety worse. They get rebound anxiety, and it can be hard to tease apart. So the message here is with patients with anxiety, you want to start with very low THC, a 20-1. CBD to THC usually works best, and really considering that when you're doing the treatment protocols. So there's no direct RCT evidence that cannabis directly treats depression. However, there's emerging real-world evidence from the drug science group, David Nutt's Imperial College group, that I sit on their advisory board for in the UK, that it does help with depression in the evidence that's being collected currently from patients who are using medical cannabis in the UK. I have seen the same thing in my practice for many years. So it's not an instant cure for depression, but it can help. It can help with the anxiety. It can help with the sleep dysfunction. Even a small amount of vaporized cannabis can help lift the mood and the energy levels in people who are really have a lot of fatigue with their depression. And depression, from an integrated medicine perspective, it is really a final common endpoint. There's many different types of depression. This is starting to play out in the research. There's some evidence now to show that some types of depression may be really inflammatory based. And we know that cannabinoids are anti-inflammatory. We know that there's a role for microglia in the brain with depression. And we also have the emerging world of therapeutic psychedelics, which is very effective for treatment-resistant depression. So oftentimes combining ketamine, which is the only one we can currently use, or a therapeutic psychedelic, hopefully we'll have access to more soon, clinically, with a cannabinoid can be life-changing for someone with treatment-resistant depression. So it's coming. Important thing about CBD, we see a lot of CBD advertisements in the UK and in North America still that just take all the CBD right before bedtime and it's going to just knock you out, just like a sleeping pill. Unfortunately, for most people, it doesn't work that way. In fact, if you take a huge load of CBD right before bedtime, it can increase the wakefulness centers in the brain in at least a significant percentage of people. And this is another thing I found clinically before it was ever talked about in the research. So what you can use high CBD products for, even hemp CBD products for, if you're advising your patients on consumer products, is to help with the stress response. So in integrated medicine, we talk a lot about the stress response and the cortisol response, and your cortisol, your stress hormone, should peak in the early morning. It should be nice and low in the evening. But when you have chronic stress burden and reversal of those sleep-wakes, the circadian cycles, your cortisol peaks in the evening. So you feel tired but wired. Most of my patients are tired but wired when they come to see me. And it's just really confusing because they're so exhausted, but they can't get to sleep. So using CBD throughout the day to lower the cortisol response can be an effective strategy. I also combine this with sleep-wake cycle retraining, with a mindfulness-based meditation, with relaxation practices, with other botanicals. And it can be very useful in that way. Another thing to mention, a lot of my patients have found over the years that their sex life improves when they go on medical cannabis, and they usually, a lot of them tell me about it, and they're very excited to report that it's really helped with their libido or other elements of their sex life. And what the message is really is a little bit of THC can help with libido, but too much THC is generally not good. So a little bit can go a long way, starting with high CBD products. And And, I'm not prescribing it for this, but a lot of my patients with chronic pain, if you actually ask them about, how is your sex life? How is it? They'll say, oh, well, no one's ever asked me, but it's bad, because they're in pain all the time and they don't have a libido. So it's a really important human function, and cannabis tends to improve it. Okay. I've already talked about the CBD and stress response. There's some preliminary evidence that it works in some of the brain stress response networks, CBD. And okay, this is one of my favorites. So this is very close to my heart. I have people in my own family who suffer from chronic fatigue and ME. We now know that there's probably quite a big mitochondrial dysfunction component to ME and chronic fatigue. And this is different than mitochondrial disorders, which Bonnie talked about earlier, but it's related. So mitochondrial disorders are a clear genetic condition where the mitochondria just don't work really at all in a certain way, versus mitochondrial dysfunction is more of a spectrum of mitochondrial problem. In patients with a lot of this chronic fatigue, illness spectrum, long COVID is probably in there as well. I've just worked on a paper that's coming out soon about this. And with chronic fatigue patients, cannabinoids tend to really be helpful for them, but you have to find the right product and you have to go very, very slowly with them because they are very sensitive to anything you give them, especially THC. So I do use THC and sometimes they need it, especially in the nighttime, but it's very, very ultra slow titrations for these patients. And sometimes once we get them used to THC in an oil form, a very low dose, then sometimes I'll use a little bit of vaporized cannabis in an uplifting strain to get them going in the morning. Most of my chronic fatigue patients who are quite severe, it takes them 3 hours to get ready in the morning. So I'm talking about from the time they wake up, their eyes open, they're in bed, to the time that they're able to go out to do a grocery shop. Most of them can't really work in the same way. So 3 hours. So one of the clinical endpoints I look at is how long is it taking them to get going in the morning? And we can usually get it down to under an hour. And that still sounds like a long time, but for someone with chronic fatigue, that is life-changing. You've just given them back their morning, basically. And there's no good drugs for treating ME and chronic fatigue, as we know. Oh, and I should also say I use things like LDN, low-dose naltrexone, alongside cannabinoids with some of these things. It doesn't always work, but it's always something good to try. Oh, I'm going the wrong way. Here we go. Okay. Now, you can't hold me to this, but everyone always wants this slide. So this is a very general starting dosage range. Some patients are much higher than this because they've already tried something like an over-the-counter hemp CBD, so we know what they're responding to. They're already on black market cannabis, which they may not know. We may have to send it to a lab and see how much is in their Rick Simpson oil and then work backward from there. So if someone's on a black market cannabis product and they're tolerating it well, I'm not going to start them on 1 milligram of THC because it's not going to do anything, and they're going to get really frustrated really quickly and go back to the black market stuff they're using before, which has who knows what in it, and that's the problem for medical use. We want to be as scientific as possible about using this as a medication. But that being said, when you start at really small amounts of THC and you start in the evening, I tell patients to start on a weekend if they're naive, and I go slowly with the THC. I go a lot more slowly than some of my colleagues in Canada, but what I tell patients is you have to be a bit more patient when you go this slow, but you get less side effects. And then when people get less side effects, they have less adverse reaction to THC, which normally if someone has an adverse reaction, it's not a big deal in that, you can just stop their THC dose for 2 days, you do a washout, the symptoms go away, but it scares them, especially my patients who are older, who have never had any recreational drug use experience at all. Putting them into an altered state is very scary for them. So it undermines the doctor-patient relationship. It undermines their sense that they want to continue with cannabis. So I try to avoid that. Okay, so what do you have to do if you have a patient who has THC side effects? Some people are very, very sensitive to THC, and some people are not. The wide range is always incredible to me. I am very, very sensitive to THC. Some of my patients can have large doses of THC and be completely non-intoxicated. because they're habituated, but also because their endocannabinoid system is probably slightly different. These are not people who are completely healthy. So these are the things you can do. You obvious one, reduce the dose, change the strain to a different product, and add more CBD, take it earlier in the nighttime, this sort of thing. I didn't talk about THCA, which I did want to. I'll talk about it here. I have 5 more minutes. So I use basically high CBD oils as a base, but I also, like Bonnie, have a few patients who cannot tolerate CBD. They can tolerate THC, but not CBD. This is so interesting to me. And these are patients with mitochondrial dysfunction, not mitochondrial disorders. So they're patients with chronic fatigue, unexplained neurological symptoms, complex regional pain syndrome. And there's only a few of them, but they can often tolerate the THCA well, because often the same people who cannot tolerate CBD, because it makes them feel worse, it actually makes their symptoms worse, they're also sensitive to the side effects of THC. So the THCA added to some THC seems to be a good alternative. And I have been pressed in the past for research. Well, Dr. Gordon, what is the published evidence for this? Well, it's not really there. I have to be honest with you. And I tell my patients this. I said, look, there's only anecdotal evidence for this, but THCA generally is, non-psychomimetic, it's not intoxicating, we use small doses, and sometimes it makes a big difference. Okay. I don't have time to go through all this, but this is what I use it for currently. I cannot currently prescribe for tumor effect in the UK. It's really complicated in cancer. Cancer is a very complicated group of illnesses. This is not a single illness. And we have a lot that we don't know. There's some tumors that may respond negatively to high doses of CBD, high doses of THC, or both. There's some tumors that respond really positively to high doses of THC. So most of the time we just don't know. What else do I want to say? Because I know in the interest of time. Okay, I want to get to this. Generally, medical cannabis is extremely well tolerated. It's better tolerated than any of the other medications I prescribe for chronic disease management. And as we heard from Professor Hart earlier, this whole thing about psychosis, which I'm going to get to here. There's drug-induced psychotic episodes that are single, and people never go on to have a chronic psychotic disorder like schizophrenia or schizoaffective disorder. That's most of the people who have a psychotic episode from cannabis. But there are people who go on to have those conditions. Now, were they going to go on to have that condition anyways, and this just unmasked it earlier? That's probably most likely, but we don't know for sure. So in clinical practice, we also have to take it into account things like medical legal action. When I prescribe someone, I have to go in front of a jury of my peers if it goes wrong and say, Dr. Gordon, how can you justify what you have prescribed? So in general, if someone has, a history of psychosis, even if it's a single episode psychosis, if they have a first degree relative with schizophrenia, schizoaffective disorder, and they're high risk, genetically, they're vulnerable. If they've had an episode of mania and they're bipolar, generally we don't prescribe THC oils, THC products. We stick to CBD. And even that would be considered very avant-garde with most conventional doctors. So I think that these CBD products are generally quite safe. There's some preliminary evidence that CBD is actually mood stabilizing. One interesting study looking at CBD as an antipsychotic. So CBD, very safe in these conditions. But you definitely wouldn't want to be prescribing someone high THC products. Specific cancer immunotherapy drugs you want to avoid. Cannabis at the same time. I delay the cannabis till later, till they're finished. Pregnancy and breastfeeding, lack of research at the moment. There's a big study that just came out. Everyone was all very concerned about it, showing that there might be some metabolic abnormalities from kids who were school age whose mothers had high THC smoked cannabis use in the pregnancy. However, it was an observational study. It was not a causational effect. As we heard from Dr. Hart, same methodological problems. And I think it's probably pretty low risk, but we don't know. So I don't prescribe it in pregnancy or breastfeeding because I can't defend it legally. And there are some cases where I would consider it, though. However, someone who is epileptic, who's pregnant, who has failed other anti-epileptics that are safe in pregnancy, anti-epileptics in pregnancy, safety it's a relative term anyway. So there's gray zones everywhere you look. I don't have time to go through this. There's some cardiac risk if you start a high THC cannabis product with a naive user and they have a high risk of cardiac stuff, but I use this in high cardiac risk patients. Low dose, start with THC very, very small in the beginning, slowly titrate to avoid increased cardiac work, and usually works very well. Okay, we've talked about this. There's lots going on in the UK. We're doing lots of policy work. Things are changing. There's been, I think, 20,000 patients prescribed now in the private sector in the UK. Sadly, that's in the private sector. So what we're working on is to get this publicly available as a funded medicine. The positive side effects. Most of what I see are positive side effects. This man, the drums, this was a professional musician I saw. He was disabled for many years on opioids, had no life. He came to me, we started him on medical cannabis, and he started playing professional music again and gigs. And over video conference, he played me in his new home studio, a little mini concert. He surprised me. It was very sweet. And this gentleman on his horse is a rancher that I saw in Alberta. He was in his 70s. He loved getting on his horse and going around his ranch. He couldn't anymore because of his disabling arthritis. And we put him on very low THC, very high CBD medical cannabis, and he was able to get on his horse again. So it's really life-changing for people. It's the best quality of life medication that I have available. And I think that patients deserve to have this in their arsenal. How many? Are we on to questions? 0. We have 0. Okay. Thank you. I'll take questions.
Thank you. Right on time. I guess we have time for about 3 questions, so please raise your hand. Those of you who want to make some questions. Okay, there you are. Yeah, we don't have too much light. If we can have a little bit of light, so we can see the audience. Thank you. I think it's on. You just need to put it right close to your mouth. Yeah.
Perfect. So first of all, thank you so much for the valuable information and for the work you have been doing. I just wanted to ask you, what is the impact that patients and doctors and your prescriptions have on the consistency or lack of consistency of available products in the market, and also about, again, available information or the lack of information you have about the products that are available?
So I'll speak to the UK because that's currently where I'm practicing, and we're in Europe. So in the UK, we have medical cannabis companies that have come into the market, and they have a variety of products available. The products are increasing all the time. In my clinic specifically, I'm not affiliated with any company. I'm one of the only clinics that's not in the UK, as far as I know. So I prescribe whatever product I think is best for that patient. So there are, now you're gonna ask me how many companies there are, and I'm not gonna be able to tell you off the top of my head because it's always increasing, but there's quite a few to choose from. And so they measure the CBD content, the THC content. They have to report this, they have to have it tested, they have to have it approved by the MHRA, which is our medical regulator in the UK. So it's all very reliable. And then more and more, we're pushing for these companies to have to report their minor cannabinoid profile and their terpenoid profile. You're not gonna get a terpenoid like a quantitative, because terpenoids are so small and you have to do all this fancy stuff to work out exactly how much they are, and they're so small. So you would say, oh, it's a myrcene-rich product. Myrcene is one that's really important because myrcene-rich products often make patients feel more sedated. So if I have a patient with chronic fatigue syndrome, this is actually quite common, comes to me from another clinic, they're already on a medical cannabis product, high CBD product, might be a great product, but it's high in myrcene because myrcene is the most common terpenoid. It's one of the most common chemovars, actually. Then they might be getting better anxiety control, but their fatigue is also worse. So we would look for a product that's lower in myrcene. So, yes.
Thank you. Another question? Anyone? Please raise your hand if it's the case.
Oh, hello? Hi, doctor. I have plenty of questions for you. I'm here in the back.
Oh, right
Thank
there.
You. Sorry, I saw you looking.
It's almost
so
impossible to know.
I apologize. So yeah, thank you for your talk. Your lecture was very informative, and I actually have many questions for you. So I hope to meet you in just a few moments and pick your brain a little bit more. So yeah, I guess just one of the things would be you initially spoke about starting doses and titrating for, you mentioned both high CBD oil and THC oil independently, but not necessarily a combination of both. And then I was also wondering about using THC, but different delivery methods to kind of help tolerate the high. So, you know, as you mentioned, vaginal or rectal applications in people who have titration issues or people who have already reached their where the biphasic effect is starting to kick in because their cannabinoids are oversaturated. So if this is something that you currently use, and then also vaginal, if you do have any, if you see a relationship with cervical and breast cancer as well, if that's an interesting delivery application for those types of treatments, because I know rectal for anything that's kind of from like the belly button down, it's a very effective way to treat, and also, you know, because of the first class evasion, so it's helping to tolerate the high a little bit better. But yeah, through vaginal in particular, if you see a relationship for a benefit in, you know, in so not just for that localized area, but also for the breast and potential other areas as well. So that's it. Thank you for your time, and I'll pick your brain a little bit more if you let me. Thank you.
Thank you. Okay, I'm going to start with the first one, which is I spoke about the oils separately. So in most of my, well, it's a really difficult question to answer because this is not a one-size-fits-all medicine or group of medicines. However, a typical patient with, let's say, chronic pain, anxiety disorder, and sleep dysfunction will come in, and depending on the person, we may start with only a high CBD oil for daytime, and we'll dose it 2 or 3 times a day. And if they have sleep dysfunction, we'll probably start with a high THC oil, which is an indica strain or a calming chemovar, more technically accurately, about an hour before they go to sleep. There's some patients where they are really scared to start any THC products, so we'll just go with the 20-to-1 CBD product during the day first, get them used to that, and then ease their way in if they need it. I also had a patient recently, and you know this happened many times in the past, where I thought she would need a small, very, very small dose of a high THC product at nighttime for her pain. She had Ehlers-Danlos syndrome, lots of pain, lots of neuropsychiatric symptoms, lots of anxiety, all treatment resistant. And she responded so well to just the 20-to-1 CBD oil dosed 3 times a day. And we didn't need to add, so far we haven't needed to add it, and she's 3 months in. So that was, you get surprises sometimes. Generally, I start with oral products as the base of therapy. They're the most widely available. It's the conventional way of prescribing these kind of, especially in the UK. I have to sit down at my appraisal every year in the UK, coming up next month, and talk to a responsible officer who has no idea what cannabis is, probably thinks, what the heck am I doing with people? And I have to, I have to explain what I do. So it has to be somewhat within the realm of, evidence-based. So inhaled products. Inhaled products are great for breakthrough pain. They're great for migraine abortion. They are good in patients with social anxiety and panic disorder. But in social anxiety and panic disorder, you got to go very high CBD flower, very low THC. Otherwise, it can all go wrong. And sometimes if they use a balanced flower, like a 50-50 with anxiety disorder, they get a good response first, but then they get a rebound anxiety, and they don't realize it's from the cannabis. And sometimes the doctor doesn't realize it's from the cannabis, so it can get quite confusing. So that's how I don't use inhaled products as the base of therapy. I'm trying to think if there's probably an exception I can find to that. I'm sure there is. There is. I have a few exceptions to that in my practice, but generally I stick with the long-acting oral forms. The vaginal forms at least utilized because there's no commercially available product. And again, this comes down to medical legal stuff as well. And I can't look like I'm too crazy what I'm doing with patients, but I have used it in Canada, because in Canada you have a lot more leeway. I haven't been so brave here yet, but I probably will at some point. What you have to do is you have to find a jury of your peers. I have to consult with a gynecologist, see if they think this is appropriate. What you would do that for? You might do that for someone with chronic pelvic pain. Which is kind of a complex regional pain syndrome of the pelvis. It's very difficult to treat. And you might also do that in someone with interstitial cystitis, which I've done it in Canada for. It has helped. Doesn't cure them, but it's really helped. And very well tolerated. You get some systemic absorption, but it doesn't seem to intoxicate them. So you can start with a high CBD. per vaginal capsule, and then you can increase this THC amount as you go, either mixing two products together, depending on what you have available, or now we have these one-to-one products. Rectal, I've used it a few more times in the vaginal route for a few patients with chronic prostatitis. I had one patient, we did it, there was no precedent, but I said, let's try it, because everything else has failed. The surgeon agreed. It was in Canada, again, more liberal than the UK, and he just got a lot better. It just really worked. So then he told someone, a friend of his that actually also had a chronic prostatitis. It just kind of spread like that. So in the end, I had a handful of patients that it all seemed to help. And then same thing, we started with high CBD, low THC, and then escalated. We don't know the optimal ratios for all these things yet, unfortunately. It's just really clinical, anecdotal evidence only.
I'm sorry, I really need to, no, don't leave because I'm having a request. It needs to be a really brief question and brief answer.
Yes.
So let's go.
Good morning, Dr. Gordon. My name is Paul. I would like to know how cannabis react with Limitroff disorder personality.
Sorry, with the?
Limitroff disorder personality. Borderliner disorder, Limitroff disorder.
Oh, sorry.
Limitroff or borderliner.
Borderline. Aha, yeah. Yes, I will answer this. Okay, this is a great question. Oh, this is going to be hard to be brief. So borderline personality disorder is a neuropsychiatric disorder. It's very complex, it's very poorly understood. Cannabinoids it's not a cure, but certainly can help with the anxiety components. These patients have high comorbid mood disorders, as I'm sure you know if you're asking this question, you're probably a psychiatrist. Anxiety helps them engage more with therapy, so you can use it. It's not a recognized indication, but if they've tried other medications, of which there's no good medications for borderline, like DBT is the best therapy we have, I don't see why not. And they probably have gut-brain things going on with borderline, so I also put them on a ketogenic diet. That seems to help with some patients as well, and probably some neuroinflammation going on. So it's yes.
Now another applause, please. You will have time. I'm sorry. I'm sorry.
It's okay.